Good morning to all the regional directors and students. I, Mrs. Rita Devi, School of Health Science, Lecturer School of Health Sciences, welcome all of you to this last teleconference of the year 2008. Today, there will be 3 sessions for post-basic BSc second year students. And we have nursing experts from New Delhi. On my extreme right, Mrs. Ranjit Kaur. She will be taking medical surgical nursing, cardiovascular management, and Madam Harinder Goyal, senior faculty member from RAK College of Nursing. I welcome to all of experts to this session. And before we start today's session, I would like to request all the regional directors to please send the attendance of the students who are attending this teleconference session. I would like to start because today we have taken the topic of cardiovascular disorders. So these cardiovascular disorders includes not only affect developed countries but also developing countries like India. So first of all, we will be discussing about the sign and symptoms of cardiovascular disorders. Ma'am, would you like to discuss?
Okay. As we know, cardiovascular disorder is one of the very important problem which is affecting many people all over the world, and we must know how to take care of the patients suffering from cardiovascular problems. There are many, and for giving care to such patients, we need to know what are some of the clinical manifestations they have when they suffer from cardiovascular problems. The first and foremost thing what they experience is that is the chest pain. Now, chest pain, we need to differentiate whether it is the pain is due to myocardial infarction or it is due to angina pain, because these two terms are generally used when we say that the patient is suffering from cardiovascular problem. Angina pectoris pain, that pain, that is also, it's a severe type of a chest pain which can radiate to the jaw as well as to the arms of the patient. But it can be relieved by if the person takes rest, and it comes generally on exertion. And even if the patient takes if the patient has been prescribed nitroglycerin tablet, if the person takes that tablet, it gets relieved. I mean, this is how we differentiate. But whereas myocardial infarction pain is a very crushing type of chest pain, it can come all of a sudden even when the patient is on rest, because it's very essential to differentiate whether the person is having myocardial infarction or angina, because in myocardial infarction the pain does not get relieved even if the person takes rest, neither it gets relieved by giving a nitroglycerin tablet. So one is differentiation. So chest pain is one of the very essential and the common complaint the patient has suffering from the cardiovascular problem. The next problem which they have is that is the shortness of breath, because as we know, heart functions as a pump, and as a pump means the blood supply to the whole of the heart, and when the heart is affected due to this myocardial infarction or angina, the heart is not able to perform its regular function. So with the result, the blood is not pumped to the lungs. So with the result, the oxygenation, proper oxygenation does not take place. So with the result, the person has a shortness of breath. So we will find that the patient has dyspnea on effort, and even the person has difficulty in breathing while lying down. So person tries to sit up to breathe because he feels more comfortable when he is sitting up. And also they may have paroxysmal nocturnal dyspnea, that is dyspnea that is difficulty in breathing during the night time. Another common clinical manifestation is that is palpitation. Palpitation is, you can sense your own heartbeat, that complaint the patient may come with, that I can hear, I walk few steps and I can hear my heartbeat. I mean, that's the beginning signs of palpitations in a patient having cardiovascular problem. Another common manifestation is syncope. Syncope. There may be temporary loss of consciousness consciousness, means like a fainting attack patient may have, and the patient recovers spontaneously due to syncope. And sometimes it is again due to less of blood supply to the brain. So one must not mistake this fainting sensation with the other problems of central nervous system. So we must try to evaluate what is the problem like. Then another problem which the patient may have is that is called intermittent claudication. Intermittent claudication is there is a pain in the legs which is felt by the patient due to arterial insufficiency. This arterial insufficiency also because of the lack of tissue perfusion. So patient will have severe pain in the legs, which is pricking type of pain, and the patient's legs become numb. And there is, as there is less of blood supply to the extremities, we will find that the extremities on touching, they appear to be cold. Now there are certain abnormal sensations, when we have the patient having intermittent claudication, you will find the patient having pain during rest in the digits as well as in the forefoot. There is a cool sensation, and the person has a numbness of the limbs. And if we hear with the help of a stethoscope, there is a bruits felt, that is sounds which reflect the turbulent blood supply to the blood flow through the artery. So this shows there is some kind of arterial insufficiency which is causing the person having leg pain.
After knowing the sign and symptoms of the cardiovascular disorders, out of them chest pain is the most important, and you can differentiate also the chest pain, whether it is due to cardiovascular disorder or due to just simple another respiratory disorder. So madam has explained it very well, the chest pain. And now how to assess the cardiovascular disorder patients? We have to assess them by certain parameters. So we will come to know about the assessment.
Okay. Now, as far as the assessment of the patient with cardiovascular disorders is concerned, we need to take the history of the patient, because the history is very important. History from the patient and also family history, because family history also is important, because there are many factors which we must keep in mind, like a history of diabetes, history of high blood pressure in the family. Not only patient having, but in the family if anyone is having, so because there is a familial tendency. So history of anybody suffering from heart problem in the family, that's very important. And symptoms which we have just discussed, history of chest pain, shortness of breath, excessive fatigue, any abnormal skin color, coldness of skin, fainting attack, dizziness, any of these symptoms if the patient has syncope or any altered level of consciousness, any time if the person has had, we must not neglect all these symptoms, and we must assess the risk factors like age, sex, age in the sense because it is common among young adults, sex it is more common among males. Hypertension is one of the risk factor. Person who is hypertensive is more likely to develop diabetes. Similarly, diabetes, person having blood sugar level high or is a known case of diabetes, again is at risk for developing cardiovascular problems. History of smoking itself adds lot of problem to the heart. Then hyperlipidemia, that is excess of cholesterol in the blood, that is again it poses a risk for developing a heart problem. Family history of heart disease I have already told you. Hypertension and diabetes in the family, and even obesity is another risk factor. Person who is obese, and what kind of lifestyle the person leads, the sedentary, especially the sedentary workers who do not have much of activity in their occupation, they are likely to develop more of, they are at more of risk for this. Or in other words, we can say lack of exercise. Even if they have a sedentary lifestyle, if they do not do enough of exercise, there are chances of getting the problem of the cardiovascular problems. And it is also seen people who have a high uric acid level or who are known cases of gout, they also are at risk for developing this cardiovascular problems. Now, how do we go about physical assessment of the cardiovascular system? First of all, we have the basic steps as all of us know it, that is inspection, palpation, percussion and auscultation. So similarly, for any system assessment, we make use of these methods. So first we move on to the inspection. In inspection, we inspect the symmetry of the chest, symmetry, I mean the patient's gait, the patient's hair, to look at if the patient looks all right, in the sense any swelling around the eyes, lips, color of the lips, color of the tongue, any allergy is seen. So you must inspect the skin for any pallor. If the skin appears pale, or there is a molting or cyanosis, or any redness anywhere, or hyperemia, or any bruises, hematoma, we must keep into mind where all they are present, and any particular there is some bleeding inside the skin, varicose veins, because that also tells us about the condition of the peripheral blood vessels. Then apart from this, we need to see to the nail beds. Nail beds, we can press the nail and see the capillary refill, whether the blood comes again, I mean whether the person has a proper oxygenation. Then you also observe neck for any engorged blood vessels, because if he has engorged neck veins, that tells us that there is a increased jugular venous pressure. It means patient might be suffering from some kind of heart problem, something to do with the heart. So this is all about an inspection. Then we move on to the palpation. In palpation, we palpate the skin. When we are palpating, we are also seeing the temperature, because increased temperature could be due to thrombophlebitis if there is some inflammation, especially of the periphery. Then whether there is some moisture on the skin, because increased diaphoresis itself tell you that there is a stimulation of the autonomic nervous system, and there is some kind of problem, or the person is very anxious. So, and you also look for any clamminess of the skin, coldness of the skin, maybe the person is in shock. Excessive dry skin may indicate that the person is dehydrated, or person having coldness of the extremities. That tells us that there is a constriction of the blood vessels, or there is a vasoconstriction, which tells us that there is definitely some problem with the peripheral circulation. Then we palpate the abdomen for if there is any problem with the liver, spleen, or any tenderness or any discomfort being felt. It could be due to any fluid collection as well, because sometimes the fluid gets collected even in the heart, which we call it as cardiac tamponade, and sometimes it is in the lungs, because if the person has a fluid in the lungs, that also presses on the heart, because in the chest cavity, it's a closed chest cavity which presses on the heart, and the person may have a heart symptoms. Then we also look in the lower extremities. We look for any edema, dependent edema especially edema on the ankles, on the sacral region, pitting or non-pitting, because this tells us a lot about the condition of the heart, because patient might be suffering from congestive heart failure. Then we do the chest palpate the chest to locate the suprasternal notch, that it is normal, and you also look for the apex of the heart, cardiac areas, and look for any abnormalities. And then we do the percussion. Percussion generally it is not much it's only when you suspect the fluid collection, then only percussion is effective. Otherwise you can do the auscultation. Now auscultation, we auscultate the heart for chest sound. We hear the heart sounds and assess for their quality, the timing, the intensity, any variations in the heart sounds, because that may also tell us a lot about the condition of the heart. We also auscultate for any friction rub. Friction rub will be present in cases if there is some fluid present in the either pleural, within the pleural, or within the visceral and the parietal layers of the pericardial layers of the heart. Then we also take the blood pressure, and note the pulse pressure. Pulse pressure, that is the difference between the systolic and the diastolic pressure, because this is again an important parameter to look into. Then we check the pulses, palpate all pulses, major pulses, and compare the central pulses with the peripheral pulses, because we need to compare them for volume, the rhythm and the rate, and check if there is any abnormality in the pulse. because pulse itself is a very good indicator to tell you about the condition of the heart and the condition of the blood vessels. So then apart from this, we do assess the peripheral vascular blood vessels, though I have already told you this, what all to look for in the extremities when the patient has come to you with the problems of the cardiac problems. So, so these are the diagnostic clues we look for. We look for the clinical symptoms, then we do the assessment, which I have just told you what all do we look for, and then we do certain tests if they are found that there is something wrong with the peripheral blood supply. Then there are certain tests which are done, like Berger-Ellen test is done. This is done especially if there is intermittent claudication, if there is some problem with the arterial insufficiency. So this is done to to assess for that whether the person has exactly this problem or there is some other problem. So in this, what we do is we make the patient lie down and with both the legs elevated and knees straight, and let that be there for some time, and then you check the soles of the patient, soles for the pallor, and you see that the patient, then you make the patient lower his feet and adopt a sitting position, and within 2 to 3 minutes, normally the blood supply should come to the normal. But if it remains cyanosed, that tells us that there is something wrong with the blood supply to the periphery. So positive findings indicate defective arterial blood supply. So this is to check for the arterial blood circulation. And there is also test for venous circulation. How do we do that? We make the patient stand, we apply a tourniquet in the mid thigh firmly to occlude the superficial veins but not the deep veins, and let the patient stand for 15 seconds and check for prompt venous filling before releasing the tourniquet. If this occurs, deep veins are filling via the incompetent perforating veins. Release the tourniquet. If superficial veins fill promptly, valves are incompetent. If no proper prompt filling is noted, it means the valves are competent and veins are functioning. So this also, by this test, we can know whether there is a proper circulation in the veins. Then there are many more tests for deep vein thrombophlebitis. That is, we tie the blood pressure cuff on the unaffected calf muscle and inflate it until the pain is elicit. So this tells us whether the patient has a tendency for the deep vein thrombosis. So these are some of the tests which we do to detect the arterial as well as the venous insufficiency.
Yeah, very well explained by Madam Harinder about the assessment of the patient in the cardiovascular disorders. Like while we are doing nursing assessment of these patients, we have to keep in mind that patient has to be in comfortable position, and we have to maintain that he is calm, so that we provide him calm and peaceful environment in which the history can be taken adequately. So now we will come to the nursing management of the patient with cardiovascular disorders. So Madam Ranjit will be telling us about the nursing management of cardiovascular disorders.
Okay, coming to the nursing management of cardiovascular disorder, it is very essential to know first how it will be classified. These cardiac disorders are classified as congenital disorders, acquired and inflammatory disorders, ischemic disorders, rhythm disorders, myopathies, and hypertensive diseases. I will take it up one by one all of these. Congenital heart diseases are mainly classified as cyanotic and acyanotic conditions, and this you will study in pediatric nursing. In detail about this, you will be covering up in a pediatric nursing. So I'll take up this acquired and inflammatory cardiac disorders. Now, under these acquired and inflammatory cardiac disorders, the number one is, as you know, the layers of the heart. It is pericardium, myocardium, and endocardium. So, when there is an inflammation in this layer, and it can cause the inflammatory cardiac disorders. So, one is the pericarditis. Pericarditis is a syndrome which is caused by the inflammation of the pericardium. Now, the cause of this is either mainly the infectious disease, and the infection can be bacterial, fungal or viral. When we talk this bacterial, it is mainly the pneumococci, staphylococci, streptococci or myocardium, and then fungal is mainly either the histoplasma or candida species. Viral is a coccic virus. Non-infectious infection can also occur if the patient is suffering from uremia, MI, trauma, radiation, etc. Now, in this clinical manifestation of this is the patient will have a sudden severe pain which will be radiating to the back and shoulders, and the pain will aggregate when the patient is in lie down in a supine position. And when the patient, there will be a pericardial friction rub is there because of there is a accumulation of the fluid can be there, and there can be tachycardia. The patient will have a tachycardia and hypotension. The hypotension occurs because of the low cardiac output. The complication of this is pericardial effusion. Pericardial effusion is the accumulation of the excess pericardial fluid which can compress the adjoining structure, because whenever there is a fluid into the pericardium, it will affect the adjoining structure. With the result, the patient will have a cough, dyspnea, difficulty in breathing, tachycardia, hiccup, and there can be muffled heart sounds are heard. Now, cardiac tamponade. As Madam Harinder has already said, that cardiac tamponade is a bleeding within the pericardial sac. So, this is an emergency condition. If this condition occurs, there will be development as pericardial effusion, and patient is often confused, agitated, restless, has tachycardia, tachypnea and engorged neck vein. BP will be greater than the pulse paradoxical inspiration drops in systolic BP greater than 10 mm of Hg, and there will be increased jugular vein pulsation. Now, diagnosis is mainly done mainly by the clinical manifestation, by taking the X-ray of the patient and echocardiogram. Treatment is, it will be given as per the cause, what the patient is suffering from, and anti-inflammatory drugs are given to the patient, and steroids is to be given to the patient. If it is because of the tuberculosis, then ATT drugs are given to the patient. Nursing management is very important in this case. You have to monitor the blood pressure, pulse, temperature, respiration, diaphoresis, the increased jugular pressure, and assess in the patient for the cardiac position. The patient is to be kept in a supine, in a leaning forward. That means in a forward position you will make the patient to sit and with the table in front. Now, to remove this, if there is accumulation of the fluid, and then the technique, the procedure which is to be performed is pericardiocentesis. This pericardiocentesis is a specialized procedure which is done in the OT, and in this, the pericardial, by putting a needle into the pericardial, and that is 16 or 18 gauge needle is inserted, and then the procedure is performed. But this has to be done, since it is directly putting a needle into the heart, that means this procedure has to be done directly under in a clean sterile technique, has to be followed. Then clinical manifestation, then there is another condition, that is myocarditis. Myocardium, as you know, is a middle layer of the heart, and is an inflammation of the myocardium is known as of the heart muscles. Now, causes is again the same. It can be viral, bacterial or fungal infection can occur. Non-infectious causes are the uremia, collagen vascular diseases can be associated with acute pericarditis. Clinical manifestation is that the patient will have sudden onset of ventricular dysrhythmias without showing any evidence of the cardiac disease. That is, if there is a ventricular dysrhythmias occurs where the patient is not showing, had no sign and symptoms earlier presence of the cardiac disease, and clinical features range from a benign course without any overt manifestation to a severe heart involvement, or the patient can have the sudden death of the patient can occur because of this. Diagnosis: X-ray chest shows cardiomegaly, ECG shows there is a conduction defect or there is a low voltage, QRS complex, echocardiogram, there will be a decrease, left ventricle contractility is seen, and then myocardial biopsy. Treatment is, we have to find out what is the cause of the myocarditis. Then mainly the patient is given the steroid therapy and symptomatic treatment is given to the patient. The nursing management in this condition is that we have to prop up the position, give a proper position to the patient, monitor for the signs and symptoms and laboratory tests, monitor adequately for the cardiac output and hemodynamics. That is, you have to see the blood pressure of the patient, pulse of the patient, heart rate, peripheral perfusion, capillary filling. You have to see the urine output of the patient and level of consciousness. Very important is that administer the oxygen to the patient. Administer the prescribed medications. Assess for any toxic or side effects of the medications. The diet which is to be given to the patient is low sodium and easily digestible diet should be given. And always when the patient is suffering from these diseases, you have to keep the emergency equipment should always be kept ready, and all the emergency drugs should be kept ready. The where the patient is to be kept, patient should be kept in a quiet environment, and universal precaution for infectious control has to be followed. Now, the next is infective endocarditis. It is an infection of the endocardial surface with microorganism. So this is the innermost layer of the heart. As you know that this can be divided into two. One is subacute and acute. The subacute endocarditis is insidious onset and less toxicity, whereas the acute have a shorter clinical course and rapid onset, and there is an increased toxicity which is caused by more pathogenic organisms. That is mainly the Staphylococcus aureus is the main causative organisms which causes the infective endocarditis. Now, predisposing conditions of these development of this endocarditis is if the patient who had a RHD, that is rheumatic heart disease, or if the patient has bifid aortic valves are there, if there is a cyanotic congenital heart diseases are there, or if there is a prosthetic valve has been put for the patient, or if the patient is intravenous drug users. Then pathophysiology of this is that since the endocarditis occurs when there is a turbulence within the heart, allows the causative organism to infect the previously damaged wall. The endocarditis is directly attached with the valves. So what will happen? There will be inflammation in the valves will occur, and there will be vegetation which consists of the fibrin, leukocytes and the platelets. When this vegetation will occur, this will lead to what it will cause? It will adhere to the valves of the heart. So when there is any additions into the valves of the heart, what it will cause? It will cause further stenosis, and that will aggravate the symptom. The infection spread to the heart valve leads to a valvular incompetencies. This can lead to patient can have a sign and symptoms of congestive heart failures or generalized myocardial dysfunction, and sepsis can occur. Now, the clinical manifestation is, one is the evidence of systematic infection. In this, the patient will have, because there is an infection directly occurring into the heart, so patient will have the fever, chills, rigor, night sweats, loss of weight, arthalgia, arthritis, back pain and muscle pain will be there. Whereas there is a evidence of intravascular lesions are there. That is very important to see, to check for it. One is a splinter hemorrhage. The splinter hemorrhage is a black longitudinal streaks that may occur into the nails and the beds. Then there is a Oslo nodes. These Oslo nodes are the painful, tender, red or purple pea-sized lesions seen on the fingertips or the toes of the patient. Then there is a Janeway's lesion flat. These are the painless small red spots which is present on the palms and the soles. You will find that the patient may have, there is a spots are there on the patient palms and the soles. Then when the fundoscopy examination is done, that will reveal the hemorrhagic retinal lesions, and that is called the Roth spots. Heart murmur is seen in the patient with aortic and mitral valves, or when the valves are affected. Patient, because there is a fever and the chills and directly the infection of the heart is there, the patient may go into a septicemia. Diagnosis is, you have to take the health history of the patient, and that is very important to know if there is any recent surgery has been done, or if the patient has got any dental procedure, or history of the heart diseases is there, or if there is any history of the recent infection or present. Clinical manifestation, then laboratory test is blood culture, blood complete pictures and urine analysis is to be done, chest X-ray is to be taken, ECG, echocardiography is done, and treatment depends mainly on the prophylactic treatment is to give antibiotic therapy before doing any surgery of the patient or before undergoing any dental or respiratory or any surgical intervention is done. Then therapeutic treatment is that there is a cocktail antibiotics are given. That means the higher doses of the antibiotics are given, and in which the broad spectrum antibiotics with the 2 or 3 mixed type of antibiotics like gentamicin and the penicillin is given to the patient. Then this all is regarding the endocarditis. Next is rheumatic fever and the rheumatic heart diseases. Now rheumatic fever is the inflammatory disease of the heart which is potentially involving all the layers of the heart. And what is the cause of the rheumatic fever is mainly the A-beta hemolytic streptococcal infection of the upper respiratory system. And the predisposing factor is that this is mainly present in the lower socio-economic group, people who are living in a crowded places, poor nutrition and inadequate treatment. Now pathophysiology, to understand the pathophysiology you have to see that because there is an infection of the upper respiratory tract, with the result our body it responds. When the body will produce the antibodies. When abnormal immunological response to the upper respiratory infections occur with the beta hemolytic streptococci, that can cause acute rheumatic fever, and this affects the heart and the joints. This will lead to involving all the layers of the heart and will cause it will cause the fibrosis and thickening of the leaflets. With the result, when there is a fibrosis and the thickening occur, and another thing is the SOHS bodies nodules that formed by the reaction of the inflammation and accompanying swelling and fragmentation of the collagen fibers. These all they form the SOHS body nodules are formed. These SOHS body nodules, what it will cause? It will cause the further fibrosis and scar tissue formation. And with the result, the rheumatic pericarditis affects both the layers of the pericardium, and pathological changes in the heart may occur as a result of initial attack of rheumatic fever. The clinical manifestation is, it is modified John's criteria you can understand, and the major criteria and the minor criteria. The minor criteria is the patient will come to you with the history of fever. There will be a previous history of rheumatic fever or RHD. There will be history of arthalgia, that is pain in the bones, prolonged PR interval, and laboratory findings. With the help of a laboratory findings that the patient, I will tell you about this specific laboratory finding later on. And the major criteria of this is the patient will have carditis, polyarthritis. Polyarthritis is the involvement of the many joints. Patient will have chorea and can have the arrhythmia marginatum. The arrhythmia marginatum is that there is a bright pink map-like lesions which occurs mainly on the trunks, inner aspects of the upper arms and the thighs. And then there can be a subcutaneous nodules which are present on the knees and the thighs. Diagnosis is done with the help of history and physical examination. If you will take the history of the patient will give you the history that having the upper respiratory tract infection during the childhood. So one should never ignore the respiratory infection during the childhood. It should never be ignored. And then there will be a John's criteria, will be the sign and symptoms of that will be present. The echocardiogram shows there is a valvular insufficiency is there, the walls are involved, there is inflammation of the walls have occurred, and with the result the blood flow is not very good. Chest X-ray, there will be cardiomegaly or can occur if there is a congestive heart failure is present. ECG will show a prolonged PR interval. Treatment is that there is no specific treatment to cure the rheumatic fever. First is that we have to give antibiotics is administered to the patient, and the choice of the drug is procaine penicillin is given to the patient, and then to relieve the pains of the arthritis the patient is given the acetylsalicylic acid. Corticosteroids are given to the patient if the patient is suffering from carditis. Now the nursing management of this is that the overall goal of our patients who is suffering from the rheumatic fever is that they must resume the daily activities without the joint pains and reduce the risk of residual cardiac diseases. The patient should not develop if the patient is suffering from a rheumatic fever, should not develop the rheumatic cardiac diseases.
So, rheumatic heart disease, as Madam has explained very well, is the main leading cause behind these cardiovascular disorders. So, would you like to add up, ma'am, something in the...
I think we have missed out one of the very important areas, that is, what are some of the lab tests which need to be done for the patients who are suffering from rheumatic heart disease or rheumatic fever, which are suggestive, which are confirmatory that the person has a problem of rheumatic fever. They are one of the lab tests that is called ASLO, that is anti-streptolysin O titer, that's a blood test which is done, and if it is more than 250 international unit per milliliter, it shows that the person is having this problem. And we do ESR, that is erythrocytic sedimentation rate. If it is more than 15 millimeters per hour in males and more than 20 millimeters per hour in females, that is again suggestive of that there is some inflammatory reaction which is setting in the body. Then we also look for C-reactive proteins, because in any infection with the beta hemolyticus, Streptococcus hemolyticus will lead to this presence of C-reactive proteins in the blood, which will be positive in these patients. Then if you do the throat culture, it will be positive for beta hemolyticus streptococcus, and if we do the WBC count, that will also be increased. So if these tests are positive, that shows it is confirmed that this person has a rheumatic fever, and rheumatic fever might have involved the heart, the joints, depending upon the severity of the problem.
Severity of diagnosis.
Okay,
So,
thank you, ma'am.
yeah, that is rheumatic heart disease. And would you like to just explain little about nursing management of rheumatic heart disease?
That is very important for the patient, is that our primary goal, nursing intervention is primary goal in acute rheumatic fever is, number one is control and eradication of the infectious organisms. As I told you, that if the patient especially in the children, when they have the sore throat, it should not be neglected, because that can lead into, it can involve the heart. And if the patient who is going for any surgery, or if the patient who is going for a dental procedure, should take the prophylactic antibiotics, should be given to the patient, and prevent cardiac complications and relieve joint pains, fever and other symptoms. And care of the patients with this is, we have to give the antibiotics, as I told you, and then care of the IV line. If the patient is not able to take orally, then IV line is to be given, and if sometimes it is given for giving a medication, when the medications are given intravenously. The main aim is that to reduce the workload of the heart, the patient has to be kept, maximum rest is to be given to the patient. And then if the patient is suffering from a high fever, the sponge has to be given, vital signs has to be assessed regularly, and then give oral fluids and monitor the intake and output chart. Like when to ambulate the patient, the question comes, and when we will make the patient to go for a work, that is, as soon as the acute symptoms subsides, then we can make the patient to recover and go and assume the work. And relief from the joint pain is, you give a comfortable position to the patient, and if they have a severe pain in the joints, we can use a bed cradle, so that to take off the weights of the weights from the joints, and give a discipline to the patient if they have a severe pain. Safety measures is to be taken, and we have to teach to the public, to the community, about the maintenance of the good nutrition and about the maintenance of the personal hygiene. That is very important.
Yeah, as well as psychological support to the patient and the family member, because the child is the sufferer and he knows that it is one of the risk factor for the cardiovascular disorder. So we have to prevent occurring sore throat, as well as we need to give psychological support to the parents as well as to the patient itself. It's very important as a nursing management thing. So what all preventive measures we can take for the rheumatic heart diseases? Madam Harinder would like to tell.
No,
Preventive
preventive measures,
measures,
I think Madam Ranjit has already mentioned that, we need to take measures to prevent the beta hemolytic streptococcal infections, and take an antibiotic course while going for any dental extraction. Then we need to take care of, any infection which is there in the body. It should not be neglected because it can affect any part of the body. So it's mainly, if this particular organism, offending organism is diagnosed to be there, so we have to be very careful. And we have to take the full course of treatment, that is benzathine penicillin or Panadura. It's a long-acting penicillin. Full course has to be taken if it is detected, because otherwise it can lead to later problems in the child.
And I think
Adulthood.
lifelong, that means penicillin is taken. Okay. So we have, I think, covered the preventive measures also. So that is all regarding cardiovascular disorders, and I am sure that you might have gained something. If there is any question from any student, you can please ask, or any suggestion you want to give. All the best to all the students who are going to appear for the exams, and thank you so much.